At Mayo Clinic, we were involved in an investigator-initiated protocol looking at Daratumumab, Ixazomib, Lenalidomide, and Dexamethasone for induction therapy for newly diagnosed multiple myeloma. The plan was to give the 4-drug regimen for approximately 1 year, and at the end of 1 year, there would be 2 years of maintenance therapy that would be Daratumumab and Ixazomib alone, with planned therapy discontinuing at 36 months. Our plan was to collect stem cells at the point of maximum response, but not to transplant these patients immediately. And what we actually found was that the addition of Daratumumab with a proteasome inhibitor, an immunomodulatory agent, and dexamethasone. And the key on this was they have 3 oral agents, dexamethasone, Ixazomib, and lenalidomide. And after the first 6 cycles, Daratumumab was given once every 4 weeks, was to really minimize the exposure of these patients to parenterally administered drugs. Coincidentally, this worked out quite well in the COVID era, because instead of using bortezomib, which required weekly administration, we ended up with using the Ixazomib. So patients only had to come to the treatment unit once every 4 weeks, reducing the risk of exposure of these patients to other patients in a chemotherapy unit that would result in a higher risk of contracting COVID. Now, the way the trial was designed, since it started a few years ago, the Daratumumab initially started intravenously, but there's no question that we would anticipate that subcutaneous Daratumumab would be equally effective. And we were really very impressed. I mean, we had a 24-month overall survival of 97%. And a progression-free survival of over 85% at 2 years. And so we think this is a remarkably effective regimen for newly diagnosed multiple myeloma. One of the interesting findings that we saw was not only a much higher than anticipated complete response rate, including MRD negative complete responses with Daratumumab-based induction. So we're beginning to come around to the fact that Daratumumab is likely to become a key induction therapy for patients with multiple myeloma. And this is validated with other studies, Dara-melphalan-prednisone, Dara-bortezomib thalidomide dex, Dara-bortezomib, lenalidomide, and dex have all shown improvements in response depth with Daratumumab. Our protocol also demonstrates that using bortezomib as the proteasome inhibitor. If you look at the progression-free survival curve, however, you do see that once lenalidomide is discontinued at the end of 12 months, you start to see a few evidence of progression. And that raises the question as to when you go into the maintenance phase with Daratumumab and Ixazomib, whether that's ideal, whether it should be Dara-Ixazomib-Len maintenance or Dara-Len maintenance. These are unanswered questions that require further studies, but there was no doubt that the induction with Dara-Ixazomib-Len-Dex followed by the 24-month maintenance brought very, very high, very deep response rates in patients for whom transplant was not pre-planned, and I think should be strongly considered as a valuable induction therapy, even for patients who aren't on clinical trials.